Welcome all of you to this live program on Orthopedic Principles. Today our guest of honor is Mr. Lee van Rensburg from Cambridge, United Kingdom. Mr. van Rensburg is a consultant trauma orthopedic surgeon at the Cambridge University Hospitals, United Kingdom. He completed his primary medical training in 1993 at the University of Witwatersrand at Johannesburg, South Africa. After moving to the United Kingdom in 1996, he completed his basic surgical training at the West Suffolk Hospital, Bury and completed his higher surgical training on the East Anglian Cambridge orthopedic rotation in 2005. He then went on to undertake a fellowship predominantly in trauma at the Alfred Hospital in Melbourne, Australia in 2006. Dr. Lee specializes in shoulder and elbow disorders and the care of multiple injured patients. So today it's my great honor to introduce you to Mr. Lee van Rensburg from Cambridge, United Kingdom. Over to you, Dr. van Rensburg.
Great, thank you. Today I'm going to be talking about the radial head, a step-by-step approach to doing the radial head. These are my disclosures, none really pertinent to my talk today. So we have a 35-year-old female who sustains a complex injury to a radial head, has a radial head replacement and a fairly modern radial head replacement. It's well done, but then she's immobilized in a cast with the elbow at 30 degrees for 4 weeks. And if you immobilize an elbow for 4 weeks after you've operated on it, don't be surprised if it gets stiff. And so although she has a great looking radial head replacement and a great looking elbow, she really has pretty poor function with only an arc of movement of 25 degrees. Ring and Jupiter in 2002 introduced us to the concept of the terrible triad: the fracture dislocation, the radial head fracture, the coronoid fracture, and the dislocation of the elbow, and told us how bad it could be and alerted us to the concept that if you have complex instability, you can't simply excise the radial head and the dangers associated with radial head excision. Highlighted by this case, a 47-year-old lady who sustains a dislocation, radial head fracture, and a very small coronoid fracture. She gets reduced and the post-reduction films don't look too bad, but by day 2, she's already dislocated. She gets reduced again and put into another back slab, and all back slabs do is add more weight to the arm, and she dislocates again. So because of the radial head fracture, they replaced the radial head and put her back into a back slab. By simply doing a radial head replacement, the elbow is dislocating again, and by 6 weeks, it's totally out. And this is not a fault of the radial head replacement. This is a fault of not addressing all of the injuries to the elbow and making sure that that elbow is stable and safe to move. The radial head replacements are important in the complex instability patient, in the comminuted fractures, but it's important that you do your radial head replacement well, but also address the associated ligamentous injuries and possibly other bony injuries to the elbow to make sure that it remains stable. Yeah, and a better looking cast, but still an elbow that's dislocated. She ends up with a hinged external fixator and an arc of movement just about functional. And by 8 months, she has an arthritic elbow, which is not much value to her. When it comes to stability, it's about the radial head. It's also about the associated injuries. And there's also an overlap in terms of the approach that you take, whether you use a Kocher, a Kaplan or EDC split, or a Boyd interval may approach or allow you to address different parts of the elbow injury to bring the stability back to that elbow. One more concept I'd like to bring to you is the concept of weight. Adding a brace or adding a cast to the elbow simply increases the distraction force. And so you can do a beautiful radial head replacement, but if you don't repair the ligaments and add some weight to that elbow in a form of a cast or a brace, don't be surprised if you suffer with instability. Because simply by adding a brace, you add 2 or 3 mils of distraction force across that elbow. The last thing is, once you've done your radial head replacement, you need to buy into the concept of static incongruity versus dynamic congruity. Once you've done a good radial head replacement, you need to get that elbow moving. Active movement stabilizes the elbow, as shown us by Duckworth's paper from 2008. Active exercises, firing up brachialis, pulls on the slope of the coronoid. Biceps, whether you're actively supinating or actively flexing, pulls on the radial head, reducing your radiocapitellar joint. And so it's important after your radial head replacement that you get that elbow moving, perhaps avoiding varus stress. And you place a varus stress on your elbow when you reach out to the side, when you abduct your shoulder. So on my post-op notes after I've done a radial head replacement, active exercises, active flexion, active supination, but avoid shoulder abduction for 6 weeks. What are the indications for surgery for radial in general on the radial head? Well, if there's a radial head fracture and a bony block to rotation, or in the context of complex elbow instability, where there's a fracture and an unstable elbow, you can't simply excise the radial head. And so if you can't fix the radial head, you need to replace it. And so in that context, we're talking about the terrible triad, the proximal ulnar fracture dislocations, and don't forget the Essex-Lepresti lesion, acute longitudinal radio-ulnar dissociation, the rupture of the interosseous membrane. If you just excise the radial head, you'll get proximal migration of your radius and incongruity at your DRUJ, your distal radial-ulnar joint at your wrist. Where's the radial head classifications? There's 3 from Mason in 54, and he talked about undisplaced, marginal rim fracture, and then a multifragmentary fracture, and showed us the various pictures of what he considered would be a Mason 1, a Mason 2. And in fact, he never showed us the Mason 3 because he excised the radial head. Now, you can excise the radial head. Outcomes are good and long-term outcomes are good, but you can't excise the radial head if there's a significant ligamentous injury. And when you look for the ligamentous injury, you'll find them about 80% of the time in those Mason 3s, the ones which might be an option for radial head excision. In the day of the 1950s, when Mason was around, the axiom was, if in doubt, resect. And I think that was mostly because they didn't really have the implants to be able to replace, and they didn't have the implants to be able to fix. Yeah, he's resecting a relatively undisplaced radial head fracture, which I probably wouldn't have operated on in the first place. Hotchkiss adapted the Mason and said whether it's minimally displaced, less than 2 millimeters, displaced but amenable to internal fixation, and then the fracture not amenable to internal fixation, the type 3. And now when we're getting into 1997, we're starting to suggest that you should try and fix them where you can, and only do an excision in the low demand patient. The implants coming in that we can now fix radial heads. And then by the time we get to 2006, we're now starting to get reasonably designed radial head replacements so that we can start replacing radial heads. Hotchkiss in his paper 97 highlighting this associated injury, the injury to the ligaments. It's not just about the radial head fracture. It's not just about the radial head replacement. It's about dissociated injuries. Roger Van Riet highlighted that beautifully in his variation of the Mason classification, the Mason Mayo of 2000. And that's why I focus here. It's not the radial head, but the associated injuries, injuries to the coronoid, injuries to the lepronon, lateral collateral ligament, the medial collateral ligament, or the interosseous membrane. Think of that Essex-Lepresti and the DRUJ. So when do you fix and when do you replace? Well, you fix it, in my opinion, when you can fix it. In generally, you can fix it when there's 3 pieces or less. But it doesn't just depend on the number of pieces big enough to fix. And sometimes you can get 2 pieces, but it's just the rim, just the subchondral part of the cartilage, and you can't get any fixation into it. Ring, in his article from 2011, said, fix if there's 3, replace if there's more. And he alluded to it in his article at the end that over time, he's becoming more inclined to replace the radial head. It is acceptable, I think, still in the young patient, to reconstruct the radial head on the back table and put it in as a fresh osteochondral allograft, not allograft, autograft. I'm generally a fixer. I try not to replace it unless I really have to, but what I will never do in the context of complex instability is replace. So we see a 57-year-old lady here with a dislocation, a coronoid fracture, and a radial head fracture. But this is a very interesting pattern. I'll give you a moment to look at the x-rays. Here on the medial side is the medial epicondyle. Do you see how this radial head is all the way across onto the medial side of this elbow? Do you see how the radial head is sitting anterior to the coronoid? You see it beautifully in the back slab views, how the radial head is now on the medial side of the elbow and the ulna is on the lateral side of the elbow. And so, yes, there's a radial head fracture in here. Yes, she might need it fixed or replaced, but there's a lot more to this injury than just the radial head. And we see it beautifully on the volume rendered 3D CTs. This radio-ulnar translocation, this hyperpronation injury. And so when you fix or replace your radial head, you need to deal with the injury to the coronoid, you need to deal with the injury to the soft tissues, and she ends up with a radial head replacement and ligament repair, an internal brace of the lateral ulnar collateral ligament, and a primary repair of the medial collateral ligament. Just as a point, I wouldn't put my anchor there anymore. I'd put my anchor here at the anterior inferior medial epicondyle. That's not quite the isometric point for the anterior band of the MCL. And it's very important when you choose your approach that you can get to the radial head. Did you see how anterior and medial this radial head was? And so you may want to pick a more anterior approach of your lateral windows, your intervals of Kocher, intervals of Kaplan, EDC split, Kocher, Boyd. And so when you've got an anterior translocation like this, you may want to be a little bit more anterior to be able to deal with it. Personally, I went through Boyd. This was not one of my cases. I didn't do this one, but if I had to do this one, I would go through Boyd. It's the more posterior of the approaches, but I still feel I'd be able to get to everything and see everything. But you need to be comfortable in your approach, what you can do and what you can see. It's also important when it comes to the approach that you can then deal. So what are the intervals? What are your options? Well, your first option is Boyd's interval between ulnar and anconius. My favorite interval for radial head fixation, my favorite interval for radial head replacement. The classic interval between anconius and ECU, and it's my least favorable of the approaches. It's the least extensile. It's the least, I think, versatile. And then you have the Kaplan between ERCB and EDC. And if you can't find that interval, you can simply split the EDC, the so-called EDC split. And the problems with the more anterior of the lateral approaches is the post-interosseous nerve and distal extension. And the problem with the Kocher is the involvement of that lateral ulnar collateral ligament, the LUCL, and also being able to see what you need to see. Here we see the radiographs of a 45-year-old who's had a radial head fracture. And it looks like a simple radial head fracture to me. The neck coming into the shaft at the top, a big piece of radial head off the back. And so it looks like two big pieces, really. Whoever set out to fix this one, 2 pieces turned into 3 and 3 pieces turned into 4. And before they knew it, they needed to do a radial head replacement. And I don't know if you've noticed it when you're looking at this images. Yeah, there it is. This radial head is massively overstuffed. You can see the lateral facet of the ulnar humeral joint is 4 or 5 millimeters wide, whereas your normal facet is only 1 or 2 millimeters wide. And so what happened here likely is they started with a Kocher. They did the Kocher, they tried to fix it, and it all started falling apart. And so then they extended the Kocher up proximally, up the lateral supracondylar ridge, and released the lateral ulnar collateral ligament. And after doing that, when they came to do the radial head replacement and they came to size it against the capitellum, the elbow could just be hinged open. And they just went for a bigger and a bigger and a bigger implant, hoping that that would bring some stability back to the elbow, where what they needed to do was to replace it. Now, the village policeman can tell you that this radial head is overstuffed. But is this one overstuffed? The radial head does look like it's a little proud of my coronoid, the lateral facet, and this lateral facet looks a little wider than this medial facet. You can't use this, though, the widening of the lateral facet versus the medial facet, to tell you whether it's overstuffed. You can when it's grossly overstuffed like this one, but in this one where it's a little subtle, You can't use that individually. Graham King showed us that in 2007, that there's a little bit of variability between the width of our medial facet and our lateral facet. It's only a few millimeters, so if it's way overstuffed, you know, but sometimes it can be a little bit subtle. And you don't really get that change or loss of parallelarity until you're more than 6 millimeters. And so an X-ray can sometimes be quite difficult to be sure on whether you're overstuffed. The best way to see whether an elbow is overstuffed is to see the relationship of your radial head to the lateral facet of the coronoid. Another radiograph where the radial head is proud of the lateral facet of the coronoid. But is this overstuffed? Well, our joint spaces, medial and lateral, look equal. They're not way out, but we know that that's not a reliable indicator. And one of the reasons why this is looking overstuffed is because this elbow is stiff. And if the elbow is stiff, they can't get a true AP radiograph of the elbow. And so they take a X-ray in the middle of a fixed flexion deformity. And so they take the X-ray like that. And then you see the leading edge, which is why it looks a little overstuffed. You want your X-ray, if you're trying to decide if your radial head is overstuffed or not, to be tangential to the radial head. We see the interface where our mortise, sorry, our trunnion is. And so we now know that this is perfectly tangential to the radial head. And we see how this is the same patient, how this radial head is not overstuffed. It is perfectly in alignment with the lateral facet of the coronoid. We're not measuring radial head to capitellum, we're measuring it to the lateral facet of the coronoid. And to get a good X-ray to see whether it's overstuffed, you want it perpendicular to the forearm so that you get a, once again, this medial anchor should be sitting here, not sitting here medially. Roger van Rensburg showed us that the best way to tell the height of the radial head is to see its relationship to the lesser sigmoid notch. And you can see that position in the approach, the dorsal approaches, the Boyd or the modification, the Wrightington approach, because you can see clearly then the radial head in relationship to the coronoid. Here, a classic Boyd relationship of the radial head to the coronoid. You can see it in the Kaplan because you're more anterior, but what you can't see it is you can't see it in the Kocher. And that's the problem with the Kocher. You see the least, and it's the least extensile. You do then need to take an X-ray and interpret your X-rays properly. So although you want your radial head to be in line with the lateral facet of your coronoid, don't forget the cartilage. And so in fact, if you take into account the cartilage, here they put a little copper wire over the cartilage, you see that your radial head is 1 millimeter or 2 proud of the lateral facet of the ulnar-humeral joint, and it moves proximally and distally in pronation and supination. In essence, you want it in line though. You certainly don't want it to be much longer. In terms of the width, it's not like a tibial plateau. It's not like the femur filling the whole of the lateral tibial plateau. There's a little bit of an overlap. And so often the radial heads look a little bit too wide, but you similarly don't want to increase the diameter too much. And that's why you size it off the native head. I've talked a little bit about the lateral ulnar-collateral ligament and its problems with laxity and instability. And you need to be able to repair it if you injure it, or repair it if it's been injured. For example, in the context of the terrible triads. You need to think of this lateral collateral ligamentous complex, the annular ligament, lateral collateral ligament proper, and the lateral ulnar collateral ligament as a Y. If you cut the Y in one place, you get laxity. If you cut it in 2 places, you get instability. And that's what happened in that Kocher approach. They cut the annular ligament across here to be able to get in. They couldn't see what they needed to see, and so they came up the lateral supracondylar ridge and released the superior band. Now, I'll often come with my Boyd interval and release annular ligament and lateral ulnar collateral ligament off the supinator crest, but I make sure that I get a sound transosseous repair on it. If you're coming with a Kaplan, you're more anterior, you tend to only damage the annular ligament, lateral collateral ligament complex in one place, but it's a little bit more difficult to repair, not difficult. Your fixation of your annular ligament is a little less tenuous, a little more tenuous, is a little less sound. which is one of the reasons I don't like a EDC split or a Kaplan. You also don't get a great view of your radial head or your coronoid with the Kaplan or the EDC split until you start coming up this lateral supracondylar ridge. The reason I'm focusing on this is you need to pick an approach so that you can see what you need to see, so you can replace the radial head properly, repair the ligaments soundly and solidly, so that you can be confident afterwards that you can move that elbow. Because if you don't move that elbow, you'll end up with a good looking x-ray and a stiff patient. I like Boyd's interval, that's between anconeus and subcutaneous board of ulna, peeling off the annular ligament and the lateral ulnar collateral ligament off the supinated crest. We see here on the left-hand side of the screen is the humerus, on the right-hand side of the screen is the ulna. You incise the anconeus fascia, leaving 2 millimeters of anconeus fascia on the ulna, and come into the triceps and split it as it comes onto the side of the olecranon. You peel back the anconeus muscle, and then you arrive on the annular ligament, which attaches onto the supinated crest, and you can slide your knife along the supinated crest, releasing the annular ligament. And that gets a beautiful view of the radial head, gives you a beautiful view of the lesser sigmoid notch, so that you can size your radial head absolutely anatomically. Remember, it's not sized onto the capitellum, but onto the lateral facet of the coronoid. For me, I like Boyd because I can get a sound repair. I bring drill holes from the subcutaneous border of the ulna, exiting along the supinated crest, and I can then weave a high-density polyethylene suture, modified Kessler, into my annular ligament, into my lateral ulnar collateral ligament. That would be the tissue just over there. And once you've weaved modified Kessler into that and retrograde shuttled the suture limbs through these transosseous drill holes and tie them over the subcutaneous board of the ulna, you can get a rock-solid repair of your annular ligament and a rock-solid repair of your lateral ulnar collateral ligament. Takes a bit of time getting your head around it because the picture's upside down, but your lateral ulnar collateral ligament of your capitellum to your supinated crest. And once you've repaired that, you can then repair your anconeus fascia if you've left yourself a 2 millimeter bridge. Now, Wrightington modified Boyd's interval by osteotomizing the supinated crest. And they osteotomized the supinated crest because they were doing it for arthritis. And when you get arthritis, you get these osteophytes, enthesophytes of the supinated crest, which become an impediment to you being able to sublux or dislocate the radial head posteriorly to be able to work the shaft. And so what they did is they osteotomized that little piece of bone and repaired it with anchors. They put anchors here into the side of wall of the ulna, but you could still do the same, a supinated crest osteotomy, and repair your osteotomy and shuttle retrograde through your ulna. In trauma, you don't have those same osteophytes. You don't want to damage the ulna because of radial ulnar synostosis. And so for Boyd, you would just simply peel the annular ligament off that interval. And the process of doing a radial head replacement, once you've got there, it's really about the approach and the decision-making on when to do it and when not to do it, is actually fairly easy. So here we've done I would say an EDC split on where the incision is centered. You've got 4 centimeters from the radiocapitellar joint to the pin, because it's the more anterior of the approaches, but you can still deliver the head quite easily. You need to then excise the remnants of the head. And so I'll often take a trial head from the stem, idea of how thick I need to excise for what would be a standard. And every single radial head replacement system, depending on what radial head you're using, will be slightly different. And in some you need to take more, and some you need to take less. But most of them will have a trial head on the set. And so you simply offer it up to the remnants of the head and then cut the neck. The next thing you have to do is to broach the shaft. And if you're doing a short stem, the angulation of the radial head and the axis of rotation of the forearm is taken into account by the angulation of the neck of the radius. And so you simply ream in the direction of the tube. If you're doing a long stem and the neck is no longer there, then that 10 or 15 degrees of angulation is normally built into the implant. the forearm axis runs from your radial head to the head of the ulnar styloid. And so some implants will have you reaming in the direction of the ulnar styloid as a sense check. You may square off the end with a broach, and you can also use that to lower the implant a millimeter or two if you find that you're too proud when you're trying to size it. You then take that native head and the pieces, you rebuild it, and you pick a radial head replacement that's appropriate for the size of that patient. If it's between a 26 and a 24, I'd pick a 24. You don't want to overstuff it in terms of height of the collar. You don't want to overstuff it in terms of diameter. It always looks a bit big on the X-ray because you're not really taking into account the cartilage when you're looking at an X-ray. When you look at what you would consider a normal X-ray of an elbow and one with a radial head replacement, remember that there's a millimeter of 2 around the cartilage on the normal radial head. Once you've excised it, you need to size your gap, the height of your collar and your implant, and you can build it up in this system by 2 millimeter increments. You will then assemble your size, and this is an anatomical radial head, and we know that the anatomic radial head is not a simple disc, it's ellipsoid. It has different undulations, and so you need to put it in the right orientation. And so that laser mark in white there is right and left, and so depending on the stem is universal, but you would line up your laser mark with the right or the left, and that then lines up with Lister's tubercle. You only need to worry about that if it's an anatomic radial head. If it's a simple disc, a simple circle, you don't need to worry about that lining up. And then once you've ascended your trial, based on the thickness that you've broached, so when you're broaching, you had an idea, you want a nice, good cortical fit on the anatomic press fits, you can assemble it and put the implant in, reduce the elbow, and see what it's like. Remember that the laser points to Lister's, but you need to read the operation technique of whatever implant you're using to understand where they're referencing from. If you're doing a Kocher, once you put your trial in, get an X-ray to make sure that you're not proud of that lateral facet of the coronoid. You can then assemble your definitive implant and insert it. Some implant systems, the trial will be a little bit easier, a little bit looser than the real implant. So if this is a little bit loose, don't worry about it. Often when you come for the grit blasted press fit, you get a solid fix. After you've done your radial head replacement, you need to screen that elbow to make sure that it's safe and stable to move. And although I'm screening here for varus and valgus laxity, what I really want to know is this elbow stable and congruent to within the last 30 degrees of extension? Is it stable in extension? Because if it is, then it's safe to move. If it's not, then I need to repair one of those secondary stabilizers, the primary stabilizers, the ligaments, or possibly the common flexor and the common extensor origins. And I need an elbow that'll, after I've finished operating on it, can hang out the hanging arm sign, because then I know it's safe to repair. So let's have a look. Here we see a radiograph of a right elbow with an injury to the medial collateral ligament, an injury to the lateral collateral ligament, and a valgus impacted radial head fracture, which was not amenable to fixation. Most importantly is as I bring her into extension, we see how the elbow dislocates. And as such, I can't elbow, I need to do something. Either fix or replace the radial head. And if it's 3 pieces or less, or the pieces are amenable to fixation, you fix it. And that's what I've done. I tried to fix it and I couldn't fix it. And so I've gone ahead and replaced it. After replacing it, I've repaired the lateral collateral ligament and the common extensor origin with an anchor. There it is. And I've now made sure that my X-ray is perfectly tangential to my radial head in assessing height. Now, it may look a little bit long, but I've done it through Boyd's interval, and so I can look into the interval and see that my radial head is perfectly aligned with the top of the cartilage of the lateral aspect of the coronoid. There's still some laxity of the medial collateral ligament, and so I screen it whether it's stable in extension. And there we see how it starts to hinge out in extension. It's not stable and congruent to within the last 30 degrees of extension. And as such, this elbow is not stable enough to safely get moving. And what I don't want to do now is wrap them up in a cast or a plaster or put a brace onto it. And so I'll go round to the medial side and repair the medial collateral ligament with 2 anchors, creating an internal brace between one of the sets of sutures. Before we can see the valgus laxity, before there's still a little bit after repair of the medial collateral ligament, but it's much better. And I'm not doing the medial collateral ligament because of this valgus laxity. I'm doing it because the elbow wasn't stable and congruent in extension. I then bring the image intensifier around and screen them as I come into extension. And we see now how my ulnohumeral and radiocapitellar joint remains beautifully congruent right the way into extension. And I now know that this elbow is safe to move. And so patient wakes up in a bulky bandage with the advice, active exercises and avoidance of various stress. One thing I would add is that certainly for the first 6 weeks, I would avoid passive supination. Passive supination is bad for the elbow. It rotates the radial head off the back of the capitellum. But active supination is good because with active supination, biceps is pulling on bicipital tuberosity, reducing my radiocapitellar joint, reducing my ulnohumeral joint. Active exercises are good, passive are bad. Now again, we head fracture in the context of a proximal ulnar fracture dislocation. There's an associated coronoid fracture with some fragmentation of the coronoid. And when I have a look at the sagittal images on my CT, I see a fair-sized coronoid, but it's fragmented. It's broken up into lots of little pieces. And although I've only got 3 pieces of radial head, there's one big piece, but then there are 2 pieces that are very, very small. But I know that this radial head is going to take more load because my coronoid is gone. And although you can fix the coronoid, you can put a coronoid plate on it, you can buttress it, this coronoid is dust. And so I'm never going to be able to reconstruct my coronoid rock solid. And so I'm going to have to rely on the lateral aspect of my elbow to provide more support to this whole elbow, treating the radial head in the context of the whole elbow. That was Van Rit's classification, the Mason-Mayo, the associated injuries. And so in this scenario, although if it was an isolated radial head, I possibly could have fixed it. But in the context of the severity of this injury, even though the patient was young, I've gone ahead and replaced the radial head, sized it to the sigmoid notch, fixed the ulnar anatomic, made sure that it's stable in extension, and then got it moving. Nearly finishing. The next question is which radial head? Do you do an anatomic? Do you do a press fit? Do you do a bipolar? Do you do a monopolar? Do you do a different kind of bearing surface? I don't think there's any right or wrong. This is the data from the National Joint Registry from 2020 in the UK. But in fact, when you look at radial heads, although they're in philosophies, there actually isn't one perfect radial head. You may have read this meta-analysis of 30 patients looking at revision rates and showed that the bipolar prosthesis had the lowest revision rates. When you lose revision rates as your choice for the radial head. The reason being these bipolar cemented stems aren't revised is to get out a well-fixed cemented bipolar implant like this, you would have to blow up the whole proximal radius. Whereas if it was a press fit radial head, they can be quite easily removed and therefore your threshold for revision is higher. When Denise Eigendal did her systematic review looking at 30 articles, they found that outcomes are good for radial head replacement. Revision rates are fairly high, but there was no evidence of one implant or philosophy over another. And to my reading again, I don't have a absolute, this one's better than the next. The important thing is make sure your radial head does for you what you need it to do, which is to bring stability to the elbow so that you can get that elbow moving. Thank you.
Thank you, Dr. Van Rensburg. Can you please stop sharing?
Sure.
Thank you, Mr. Van Rensburg, for this amazing presentation and wonderful collection of cases.
Pleasure, sir.
Let's have a short Q&A. Dr. Van Rensburg, now you have mentioned about cemented. I mean, you've also looked at uncemented versions, and you said that if you're going with the cemented, you have to resect a little bit more of the radius, right? So do you think cemented is out of phase? And do you think, what about the surgeon's preference or all over the world? Do they prefer uncemented over cemented?
So the current, I would say the winner, cemented versus uncemented with the radial head, would be uncemented. And then your fundamental philosophy with your uncementers are the polished, circular press fit, the temporary spacer, or an anatomic grit blasted or surface prepared for bony integration. And realistically, my reading of the literature, it's a 50-50 ball. I do an anatomic, I do a press fit uncemented. I want my radial head to go in. I want to do it well, so it's not overstuffed, it's stable, and I want it to stay there from now till the end of time. But I can't 100% say that in terms of patient outcomes, EQ5D's function, that my choice of radial head is better than anyone else's.
Thank you, Mr. Van Rensburg. And Dr. Van Rensburg, you mentioned about, I mean, in an X-ray, there was a posterior subluxation of the radial head. So do you think that was due to an attenuated LUCL? And how often do you require an LUCL reconstruction?
So yes, that was because they simply replaced the radial head and didn't deal with the LUCL injury. So in an acute injury, so a terrible triad or something that's within a few weeks of injury, often on the lateral side, your lateral injury is a bony, not a bony, it's a avulsion from the lateral capitellum, the lateral epicondyle of lateral ulnar collateral ligament and common extensor origin. And in an acute injury, the tissue is normally very good. And so in an acute injury, within about 3 or 4 weeks, you can often just put an anchor into the center of the capitellum, whatever kind of anchor, or transosseous drill holes if you want, and get a really good hold on the soft tissue. If your injury is 4 to 6 weeks, or like that case, they didn't repair it and you're coming now to do a revision case, then I think you do need to give some more stability to the elbow so that you can get it moving. And in that context, I'd often then do an internal brace. So doesn't have to be a particular company's prosthesis, but a high density polyethylene suture or tape between the origin and the insertion of that ligament. And so for that, on the lateral side, it's from the center of your capitellum to your supinated crest. And so I'll often put a double loaded anchor with the high density polyethylene sutures into the center of my capitellum, use one set of my sutures to repair, the lateral ulnar collateral ligament, my sutures to pass to the supinated crest. I only reconstruct, and when I talk about reconstruct, I'm now talking about an artificial ligament or allograft or autograft. I only reconstruct in the chronic cases, 3 to 6 months down the line, or revision cases where there's no real healing potential left in that elbow. I think most acute elbows or semi-acute elbows, you can get away with a primary repair or an additional internal brace.
Thank you, Mr. Van Rensburg. And Mr. Van Rensburg, we have surgeons from different parts of the world on our channel. And I was wondering, a cost-effective method, for example, a cement spacer. Now, you mentioned one of the papers with Amir Kuchari from Rothmans. Interestingly, I've hosted him before. And he mentioned about using a cement spacer as an alternative. Suppose someone doesn't have an access to advanced radial head replacement. Do you think that could be a reasonable alternative?
Yeah, I think that's a great solution. Yeah, I did some teaching in Egypt, and a lot of people don't have access to a radial head. And so there's nothing wrong with making your own simple cement spacer radial head. Now, to make them are actually quite easy. What you do, I wish I'd actually prepared this. I actually haven't, is you take a syringe. So if you take a 10 mil syringe, the internal diameter of a 10 mil syringe may be about 5 mils, 10 mils. The internal diameter of a 20 mil syringe will be about 15 mils. But if you take the syringe, okay, one syringe this side and one syringe this side, this is a insulin syringe, this will be a 2.5 mil syringe, that head will be a 5 mil syringe. And you wire the two syringes together and reinforce it in the center with a little bit of wire, you can actually manufacture quite a nice little cement spacer radial head. So I'm lucky, so I have access to a anatomic radial head. But if I ever get infection, or if I had an open elbow injury and I didn't want to place my metal implant there at the same time, then I make it out of methyl methacrylate. And you can get then different lengths to your head, different lengths to your stem.
Thank you, Mr. Van Rensburg. We also joined by Loy. Loy Al-Khatib is an orthopedic and sports medicine surgeon based in Dubai. Loy, welcome to the show. Any questions to Professor Van Rensburg, please?
Thanks, Professor. Hi, can you hear me?
Yeah.
Yes, perfect, sir.
Good evening, guys. Thanks, Professor, for that great presentation. I don't think there's any question left after this comprehensive talk. One of the questions, or one of the, let's go to the basics. When you can add, I'm asking about the external fixator. When do you think there's a place to add an external fixator for your elbow instability case, or after you repair an elbow, bring the elbow stable back, or repair the ligaments? When do you think that we can add can you hear that? Sorry.
Yes, great question. So the question is, when do I need an external fixator in the complex instability? And so I've always got it there, but for an acute traumatic elbow, I've never had to use an external fixator. The important thing there is that you reconstruct the bony injury, fix or replace the radial head. If it's a big piece of coronoid, fix the coronoid down, approach it either Taylor sham from the medial side, Hotchkiss, fix that piece of coronoid, the sublime tubercle, and then either repair primarily or internally brace your collateral ligaments. And so I've only really put 2 or 3 external fixators on an elbow in my life, and they've been mostly revision procedures or horrendous open injuries where the soft tissues really were just not up to having any form of internal fixation. You can use a internal external fixation, something like the IJS, the internal joint stabilization system from Skeletal Dynamics. That's pretty good. I've not needed to use it, but it's also something that I have in my head. It was a great technique from Egypt, Ashraf Moharan. If you Google temporary infixed distal humerus. So basically what they were doing was, when they had poorly fixed distal humeruses, the fixation on the distal humerus wasn't great. What they did was they put a LCP, a large fragment, narrow LCP, around the back of the elbow as an infix. And so, in fact, for me, rather than putting an X-fix on the elbow, because you just know you're going to injure that radial nerve, if I had to, I would temporarily infix you with a narrow LCP or large fragment recon plate for a short period of time if I needed to keep your elbow stable. I just don't like X-fixes around the elbow.
Got you. In that way, so this is the lead us to the second question that you mentioned about approaches. I think you are right that the Cocker approach is the least extensile approach, and I think we should avoid using it. Do you agree that using a direct posterior approach to the elbow will allow us to tackle both sides if we need, medial and lateral, and we can replace the radial head and fix the ligaments at the same time? Or you'd like to do a dual incision, medial and lateral, avoiding the one single posterior incision?
I'm a fan of the single universal posterior skin incision. So in the complex instability, I'll make a long single posterior skin incision, go down to the triceps fascia, go down to the forearm fascia, and lift my skin flaps. I do whatever I need to do to the lateral side, and I only go medial if I have to go medial. But yes, I prefer a single posterior skin incision rather than 2 incisions. And I make sure I like Boyd because I can do everything through Boyd, and I can internally brace my knuckle. And it's that which is when you tie your capitellum to the humerus that stops you PLRIing, that allows you to get it moving. And if you can get a real good sound repair, annular ligament, lateral ulnar collateral ligamentous complex, you then can be confident that you can move it. And so in complex instability, I like a single posterior skin incision.
I got you. And in terms of that, that's us lead us to the third question, which is what order of fixation you prefer? Do you go medial, coronoid, lateral? Would you go medial, radial head replacement, or coronoid fracture if you have a coronoid that you need to fix? And if you fix the radial head first, would that will prevent you, when you do the x-rays, prevent you from controlling your coronoid fracture? Is there any, I would like to hear your thoughts on that order.
So when you break your coronoid in the context of the terrible triad, you break it off this piece here, the intermediate ridge. It's the slightly more lateral part of your coronoid. It's normally a small bit of coronoid, which probably you don't need to do too much to it, okay? But yes, if you replace your radial head and you haven't done it, then you've missed your opportunity. But I always come to people through Boyd. I come through the back. And if I put a laminar spreader between my radial head and my ulnar, and I've got a radial head fracture here, I can distract the gap and I can get to the front. I can get through there to that little bit of coronoid. And to me, in the terrible triads, it's not about the coronoid, it's about that anterior capsule. It's about the proprioception to the elbow. Because if you've got a big coronoid, like an anteromedial coronoid, which is a different injury, you actually then don't often have to go to the radial head. Those I'm going to go a dedicated medial approach. So before I fix my radial head, I come through Boyd, push the radius to the side, look into the depth of my wound with a J needle, grab the capsule and a little bit of radial head, and I do my transosseous suture lasso drill holes from subcutaneous board of ulnar, shuttle them with a monocryle on a straight needle, and get them ready to tie. Now, lots of papers say you don't need to do that coronoid, and I probably don't need to do that coronoid, but for me, it comes for free because it's right there in front of me. If you do a Kocher, it doesn't come for free because you can't get to it. If you do an EDC split or a Kaplan, you can get to it, yes, but you've got to make a big approach then coming up that lateral supracondylar ridge to be able to get across to the top there. So that's why I get it for free through Boyd. So I normally prepare my coronoid or put some sutures into the capsule. Then I fix or replace my radial head. Then I will repair my annular ligament through my transosseous drill holes. And then I'm right there for the lateral epicondyle. The capitellum is here, lateral epicondyle is here. It's bare, there's nothing on there. I put an anchor into there and repair, tighten up my LUCL, my lateral collateral ligament complex proper, and my supinator crest. And often I'll then just repair it. And if I need to, take one of my sets of sutures across the gap through my supinator crest to do an internal brace, sort of belt and braces.
Still do it.
Then I'll screen the elbow before deciding if I'm going to go medial.
Okay, so you start with the lateral column first, let's say that.
Everything lateral first.
Everything lateral, okay. That's exactly, this is the message here. When you start the lateral column first, LUCL, radial head, coronoid, leave the medial side to the end, and you do your stress test and so on.
That's right. So I do lateral side and then I see if they're stable. And if they're stable, even if there is a little bit of valgus laxity, I don't go repair medial side. I only go repair medial side when I'm bringing them into extension if I get a drop sign, if it starts to hinge out. And if I can't get my hanging arm sign, I can't show the elbows rock solid stable, then I go medial. A bit of valgus laxity doesn't worry me.
Okay, got you. The last question is, do you prefer to splint or to apply a splint in pronation when you do LUCL repair?
Oh, no splint, sir. No cast, no backslap.
Nothing.
When you add weight to the forearm, in the form of a splint, you increase your distraction. And now if you're missing a little bit of coronoid and your LUCL repair is not too tight, oh man, then you drop out and then before you know, you dislocate. And the problem with splints, the patient then feels comfortable and safe, and they get the atony of their muscle. And again, you get your drop sign and you drop out. So for me, you need to be stable before, and stable enough that you don't need a cast or a splint, a bulky bandage and a broad arm sling, and my voice echoing in their ears, impressing on them how important it is to them to actively flex, bring their hand to their mouth, and how that reduces my drop sign, reduces my ulnar-humeral joint, makes my elbow more stable. The more they move it and flex it, the stabler it becomes. I don't like splints.
Okay, thanks again. Thanks for the message. I think that's it for the questions and Q&A.
Okay. Thank you,
Can I share
Professor.
my screen just for 1 second, sir?
Sure.
I just want to show that cement spacer, because
Oh, wow. Thank you.
it's just if so this is how to make it. You take a 10 ml syringe and an insulin syringe, make lots of different sizes of radial heads. Spin up a little bit of wire to make my internal wire core. So it's a rebar, yeah, reinforced. And you add a 2 ml syringe to a 10 ml syringe like this. You measure how long your stem needs to be, and it's generally about 15 to 20 mils. Just look in the optic of a radial head replacement company, and they'll tell you how long your short stem should be. And then you cut that off there. You cut that off here, and then you fill it up, and you can make your height of your radial head. So you can make 5 of them with 1 mix of cement. And that's what it looks like. The more you push the plunger, and the plunger makes the depression, and you've got the rebar in the center. And so you then just fill up the big 20 ml syringe and push the cement down. You can shape it a little bit for, to make it thing. And so now I've got a 5 ml syringe, a 10 ml syringe, a 20 ml syringe. This one, my collar height is maybe 10 mils. This one, it's 20 mils. And so you can adjust what's missing. Yeah. And then you take a sagittal saw, micro air saw, and you cut the plastic and you release it. A subtle variation to get the diameter of your stem perfect is the internal diameter of an ET tube changes. As you go up 7 millimeter ET tube, 8 millimeter ET tube, this diameter changes. Remember, it's the internal diameter, not the external diameter, but you could then wire that to your syringe, and you can then get nicely shaped radial heads. It never comes out perfect. So again, with a saw, you just smooth off your edges, and you can make yourself a beautiful custom-made press fit radial head.
Thank you, Prof.
Oh,
great.
No problem. I'm not a prof.
Thank you for adding value. I mean, this is going to benefit a lot of people, right? Thank you, Prof. That's all the questions that we have for the session. Thank you for this wonderful presentation, and we really look forward for one more talk in future.
Pleasure. I love talking.
Thanks again.
Bye-bye.